So, first of all, thank you to you for being with us today.
My
So,
pleasure.
good evening, all the students present here. Our speaker for today is Dr. Arun Raja. He is a senior clinical fellow, critical care guys at Saint Hospital in UK. He's currently working in UK. Also, he'll be taking your session today on obstetric emergency CCS session. Thank you, sir. Once more, you can start your class.
Hello, everyone. Yeah, thanks, Fatma, for introducing me. As she said, I'm currently working in London, and I passed my EDIC exam after taking a course with FOSS Academy last year in 2024, which was really helpful in making me successful. So I want to contribute back to the academy by helping out others as well. So I'll be taking few classes, few sessions on obstetric emergencies. This is going to be my first session. So first of all, congratulations everyone who is participating today for clearing part one and applying for part two as well. So you are taking a big step towards your career. EDIC exam is going to help you out in multiple ways in your career and getting advancing in your career. And you have done a wise decision by joining the FAST Academy because this is one of the very few courses available for EDIC Part 2 in particular. The EDIC preparation course given out by the ESICM, it's way expensive and you don't get as much chance for like mock like scenarios for the exam. And it's a different exam compared to other critical care exams. And it's divided. The part two is basically consist of two sessions, day one and day two. Day one is the computer-based assessments, and day two is clinical case scenarios. And we will see in more detail about them. So objectives for the class today, just to orient you towards EDIC Part 2 exam. I don't know how many are aware of how the exam is going to be. So as I said, it's going to be 2-day exam. Part 1, it's like a 30 minutes exam. You get 3 sessions of 10 questions each in the computer-based sessions. It's going to be like a rapid-fire quiz-like exam. You need to be very quick in reading the questions and answering. And day 2 is going to be like few sessions of clinical case scenarios, which we will see today. So it will be a series. It will start with a clinical scenario, clinical Vinay, and followed by a few questions. Then the case will progress. The patient will develop more complications. Then subsequent more questions, another scenario, another question, like that. This session is going to be more of a practice session for you guys. You all know the theory. You just adjusting to the exam kind of scenario and sharpening your answering skills. That's what is going to be making like helpful for you and make you successful in the exam. So we will revisit some of the pertinent obstetric topics today, and I'll try and modify your answers according to the expectations of European or UK standards. Some ground rules. Let's keep this as much interactive as possible and use this opportunity to come out and talk, like reply, answer in English, and get used to that, get accustomed to answering questions in the exam. That's going to be really helpful for you. And may I request to keep your videos on so that I don't feel I'm just talking to the screen. It's helpful to interact as well. So whoever can, please keep your videos on. And I already see your names on the screen so that I can ask questions. So we will do like this round robin kind of questioning. I will start with, I have a list of your names. So maybe I can start with Salah, Then we can progress one by one so that each of you get a chance to engage and answer. And practice answering in a structured way so that you can get maximum marks. And I will give you the answers so in the way which is expected in the exam, so you get an idea how you need to answer comprehensively. And feel free to interrupt and clear your doubts. Uh, I know I can see your names. It would be really helpful if you can unmute yourself and introduce yourself, like what you're doing, what level of training you are in critical care. Salah, do you want to go first?
Hello, doctor. Sorry, I am in duty. I cannot talk. Just I can listen. Sorry for
That's
that.
absolutely fine. That's good to know. Anyone else? Whoever is available, if you unmute yourself and introduce yourself, then we can discuss. I can ask you the questions first.
So, hi, I'm Haytham. I'm Haytham Al-Amli from Palestine. I'm a critical care specialist now in Palestine. Yeah, I completed
First.
my fellowship like 3 years ago.
Great. Perfect. Thanks, Aitan. Who is the next one? Al Mokhtar, are you available?
Yes, also I'm internal medicine and I'm doing also MICU specialist.
Great. And you are free to answer, right? Fine. And Dr. Mohammad Raha?
I'm driving, so I'll try. Once I can manage, I will definitely I will be participating.
Sure. If there is no reply, we will move on to the next person. I didn't get a reply from Dr. Mohammad Raha. Let's move on to Lee Ratnakumara.
Hello, I'm from Sri Lanka. Currently, I'm
Oh,
working
great.
as an acting consultant in the intensive care unit. I did my training in 2022 in Sri Lanka.
Oh, great. Thanks for having. Nice to have
Hello.
you here.
Hello.
Yep. Yes. Dr. Mohammad, welcome back.
Welcome. Thank you. What?
So you are available to answer, right?
Sorry, I just joined now. What is the
Okay.
question?
No, I'm just getting the introductions done. I'm checking if everyone is available to do the questions.
Yes, available. Okay.
Yeah, thank you so much. Ravi? Okay, item is here. Christina?
Hello, I'm Christina. I'm from Spain and I'm a consultant in intensive care, but now I'm working in Ireland.
Great. Nice to have you here. Okay, and Dr. Rajat? He's not there. Fatih?
Yes, hello. I'm originally from Egypt. And currently I'm working in UK as an ICU specialist as well.
Okay, great having you here, Fatih. Priyanka?
Hello, I'm working in Safdarjung Hospital in Delhi.
Oh, nice. Great. And Gibran, do we have you here? Dr. Gibran Khan? Fine. So let's not waste more time. So we have more senior people here. It's just about getting the practice of Gibran has messaged me. That's fine, Gibran. We have enough people to answer it, but if you want, you can type in your answers in the comment. I will have a look. So these are the ground rules for this session. We will try to finish it within like 45-50 minutes. So the case starts like this. You're called to an emergency code blue in the delivery suite as part of the cardiac arrest team. So the patient is a 37-year-old primey with severe preeclampsia, 39 weeks gestation, which was admitted like 3 hours ago in spontaneous early labor. She collapsed following an intense uterine contraction with no respiratory effort. Upon arrival, like 90 seconds after her collapse, CPR is still ongoing. As the most senior doctor in Athens, the resuscitation team is looking to you to lead the resuscitation effort. So the questions in the EDIC.
Sir.
Yeah.
Sir, can you
Yes,
increase
Ravi.
the size of image?
Sorry, Ravi, I didn't get you.
Can you increase the size of image of questions?
Size of the question.
Yeah, it's very small.
Okay, let me see. I need to come out and share it again. Thanks for letting me know. Right. So the questions in EDIC exam is going to be really lengthy. You need to have a lot of energy to go through that and make notes of the essential points. Before the session, like each case for the CCS, it will happen over like 2 hours. You will have 4 cases, 2 long cases and 2 short cases. Before each case, you will have some time to go through the initial scenario and make notes and prepare yourself in the mind. Then the scenarios change and you will get more questions. So feel free to have a paper and pen and note down the important points. So I've started with a small clinical case scenario, but in the actual exam, it may be much bigger than this. So who wants to go first? Salah, do you want to take this and try and answer this? Or whoever is free? I think Salah is busy in the duty. Dr. Al-Mokhtar?
Yes. Can you go back to the case, please?
Yeah.
Okay. So now, once you have resuscitation, we have to continue CPR to regain ROSC. And then we start with ABC.
Yeah.
ABC, we make sure the airways are protected, cholecystectomy for incubation, and we starting CPR. A gynecologist must be there for early intervention, and we continue resuscitation.
Right. Anything else? So the examiners
we do
won't...
ABC investigating for the child to ultrasound to make sure it's viable and see blood test and ECG. But I think the prioritizing to ABC to achieve ROSC for the patient.
Right. So in the actual exam, the examiners is going to keep a poker face. They won't give any positive feedback or negative feedback. If they want you to answer more, if they are not satisfied with your answer, they will just say anything else. They will give prompts like once or twice with every question before moving on to the next question. So if they are suggesting like anything else, it means your answer is inadequate and you need to come up with more broad answers, or you need to expand on your answers. Dr. Mohammad Raha, do you want to add on anything to what Al-Mokhtar said? Or anyone else? It's open to the audience now.
I will also inquire about use of magnesium sulfate in this patient, because this is a severe preeclampsia and the patient has suddenly collapsed with no respiratory effort. So this could be a feature of magnesium sulfate toxicity. Or I would also like to rule out any antepartum hemorrhage and placenta previa might be there. So concealed also, I will like to go for an obstetric opinion. And I will also get an ultrasound abdomen done to rule out any concealed hemorrhage, antepartum hemorrhage.
Excellent suggestions. Anyone else want to add anything? Anything else? This is going to be the examiner asking you. Anything else?
We start with positioning the patient and consult this OP doctors for possible and CS, emergency CS.
Excellent suggestions.
After confirmation viability of the fetus.
Right. So when do you want to do the perimartum cesarean section? At what time do you decide you want to go for C-section?
Within 6 minutes, what I remember, within 6 minutes of collapse.
Yeah.
Starting with.
Any other answers? Do you want to add anything else?
The European guidelines 4 minutes, the American 5 minutes, so it's 4 to 5 minutes.
Yes. So you start the decision at 4 minutes, and ideally within 5 minutes you should deliver the baby, which is not always possible, but this is what the guideline says. Yes. Anyone else?
Sorry, here, can I ask you something?
Yeah.
I have to mention need to be intubated and ventilated. We started in strobe. We do compression. We ultrasound to see if fetus is viable.
That's definitely there. I'm just looking for few
Just in the
moments.
cross match. So I have to mention all this in it because we think maybe it's
Yes.
concealed bleed. We have this in the cross match prepare. O negative if we need it as urgent. We call a theater room for possible delivery because we the time within 5 minutes.
Yeah. So in that note, we don't shift the patient in arrest while the arrest is still ongoing. We do the perimortem C-section at the same place unless there is ROSC and the patient is stable enough to be transferred. Yeah.
Yeah, definitely.
And yeah, you do need to like come up with different answers as long as the like examiners is ready to move on to the next question. You need to keep coming up with different, try and answer as much as possible. Don't repeat the answers, but try to answer like go to a different section of answer. If you answer in a structured way, you can get more marks. I will give you the answers now. Yeah.
Neonatology also should be informed and should be ready for.
Yeah, exactly. So see, with time you are
multidisciplinary
getting
team.
more ideas. With time you are getting more ideas. So let me see what I have in my answers. So first thing, I'm going to get a brief handover. In UK, or the advised handover method is S-bar handover. You go there, you get a quick handover. What's the situation? What's the background story? And S stands for situation, B stands for the background, A stands for the action, and R recommendations from the team. So this hardly takes like 30 to 40 seconds. Then we should ensure in UK and European standards, like they have a different codes like arrest calls. In a general cardiac arrest, the obstetrics and neonatal team won't be there. So we need to specifically ask for obstetric cardiac arrest, including a neonatal team, if you want them to be present in the team. So this patient, definitely we need the neonatal team to be there in case we are worried about like perimortem C-section. So that's one thing to confirm when we arrive there. So as you said, we will continue with the chest compression, and positioning, as Dr. Mohammed mentioned, is very crucial. That's going to carry a bit more mark in this particular scenario. Ensure there is a proper left lateral tilt, or if it's not possible, manual uterine displacement. We should be quite conversant with how are we doing to do that and why we do that to prevent aortic cable compression in any pregnant lady more than 20 weeks. And minimal interruptions, see if there is a shockable rhythm as soon as defibrillator is available. And you did mention intubation, but we don't try and intubate all the patients who are in arrest. Why in particular in pregnant women, we are worried about early intubation?
Edema can develop and the difficult airway management will be there.
Yeah, of course, any pregnant woman, we are anticipating difficulty in intubation, but there is also the risk of aspiration with any pregnant lady. So that's why we may get away with IGEL insertion or LMA insertion in other cases, and we try and intubate after we achieve ROS in many situations. But in a pregnant lady, this is one occasion where we try and intubate as early as possible. And as we already discussed, perimortem C-section, we discussed the time and the place. We try not to shift the patient to a theater while the arrest is ongoing. We try and deliver the patient on the spot of arrest. So that's very important. And the person, do we need an obstetrician to do it, or who can perform the perimortem C-section?
Supposed to mean anyone, even the emergency physicians can do it.
Exactly. So it doesn't need to be a specialist. Any MBBS doctor can perform if they are confident, they can do it. And what kind of incision are available, like in an emergency?
Paramedian incision, longitudinal paramedian incision.
So what's given in the guidelines is suprapubic transverse or midline longitudinal below the umbilicus. So that's what it's suggested in the guidelines.
I heard that maybe my information are outdated, but it's classically it was in the past to make, because we want to make it as fast as possible, to make it longitudinal incision, supraumbilical longitudinal incision, but maybe they changed the guidelines to horizontal. I'm not sure, but I think horizontal it will take time to deliver the baby. You will never be able, because it needs a lot of dilatation. But longitudinal upper incision is much faster.
Yeah, whichever the operator feels comfortable. But these terms are the what is used in guidelines. It's better to stick with the same terminologies so that we can avoid confusion and we can get our marks and move on to the next question. So we discussed evaluation
Sorry,
of reversible
can I ask you
causes.
something here?
Yes,
Do we need to do POCUS first to make sure that the child viable? Then we go for C-section. Because maybe you have concealed bleed. Or just
No, it's not advised. So the reasons why we do a perimortem C-section is not just to save the fetus. It's more for the mother, isn't it? Like if we deliver the fetus, the perfusion for the mother is going to get better, and maybe that's the reason why the mother arrested in the first place, like having the fetus inside. So it's not only to save the fetus, but predominantly to save the mother. So we don't wait to check if the fetus is viable or it doesn't alter the decision making. So we don't waste time doing POCUS. Yes, I understand we need to rule out reversible causes, but if there is no like expertise available in doing POCUS, you are the one leading the team, and within 4 or 5 minutes we need to decide on delivery. The C-section takes like preference over doing the POCUS. Of course, we try and do like rule out reversible causes within the time frame possible, but priority is to get the child delivered. And one thing none of you mentioned is eCPR. So this although like it's not available in all the hospitals, this is one point which may have a mark, and you may miss out on it if you're not mentioning it. So in any arrest scenarios, for the purpose of this exam, always mention like ECMO CPR in the like back end. So it may carry a mark, we don't know. So this is how I would structure my answer, and most likely this is how they would have like the answer sheet is available to the examiners. So as long as you say like even close to the answer which I have written here, they will put a tick and give a mark. There will be 2 examiners. One will be giving you the mark and one will be asking you the questions. So they will just tick and give you marks. As long as you list out as much as possible, you maximize your chances of getting the more marks and passing the exam. So we discussed a bit about cause of arrest. If Lee is available, you can take this question, Lee. Dr. Ravi?
I can answer this if it's okay.
I'm just trying to like give everyone a chance so that Dr. Aitam, if they are not available, then we can.
Yes. The causes. You mean the cause of the arrest? The obstetric causes could be bleeding. It could be massive pulmonary embolism. It could be an infection, sepsis. It could be amniotic fluid embolism. It could be during anesthesia if the patient she was in induction like anesthesia toxicity. It could be cardiomyopathy related as she is in peripartum period.
Excellent. Anyone else have any suggestions?
We should divide the structure obstetric causes and the non-obstetric causes.
Yeah.
So in obstetric causes he mentioned, but other we cannot rule also out non-obstetric causes like hemorrhagic shock or MI, myocardial infarction or whatever.
Yeah, so this is one way of putting it out. Other way which you can use is like reversible causes of 5H and 5Ts and try to accommodate all the causes within these like hypoxia.
Sorry, can I ask here?
Yes or no?
If I say for general, obstetric will discuss, but for general, I'll say to rule out 5H5T.
Yeah.
So I have to mention it or just
Yes. You can mention like generic answers like 5H and 5Ts, but you need to add in more details like specific to this case. Then you will get more opportunities to score the marks. Like for example, I have put answers like this, but you can always say like in the hypoxia, you can mention amniotic fluid embolism or pulmonary embolism and anaphylaxis given in hypoxia. In the hypotension or hypovolemia, you can mention hemorrhage. And in the toxicity, you can include local anesthetic toxicity and magnesium toxicity. And even in hypovolemia, you can include septic shock as well. So you can put it out in different ways as long as you include all these things and maximize your chance of getting the marks. Is that fair enough? Yeah. So we have somebody already mentioned, I think Priyanka mentioned magnesium toxicity. That's an excellent suggestion because this patient was having severe eclampsia. We don't know if the patient could have been getting magnesium. And if the patient was having an epidural in place, local anesthetic toxicity is always on the cards. And any maternal collapse, we need to think about amniotic fluid embolism. And it could have progressed to eclampsia given the patient is having severe preeclampsia background. And upper rupture placenta is always there as a differential as well, apart from the regular general causes of others. So we are moving on to the next scenario, next Vinay. Following defibrillation, so it was a shockable rhythm. There is ROSC, and it has taken around 4 minutes after the initial collapse. So initial blood pressure is slightly borderline low, 90/60, the heart rate of 90, and it's regular now. And the patient is still apneic. GCS is low, 5/15. So what will be the next steps? Who wants to take this question? Christina, if you're available. Or Dr. Fatih?
Yes, sir. So the question is, what precede the post-ROSC? Of course, the post-ROSC management here would include reassessment of the patient regarding the A, B, C, D, E. Regarding the airway, should be the airway should be secured, and the patient, if he was not intubated, should be intubated at that time. Achieve a breathing of assist the breathing, assist the equator entry bilateral, assist the saturation to be maintained between 94 and 98. Do a chest X-ray if it was not done yet to rule out any pneumothorax or any complications from CPR or any primary cause of the arrest in the first place. Circulation, maintain the circulation map above 65 millimeter mercury, either by a fluid or by vasopressors if needed. Assess the cardiac function by focus ultrasound or focus ultrasound if possible or if available. And then disability, reassess the GCS in details, assess the pupils bilateral, assess the temperature, assess the random blood sugar levels, do a blood gas, and target to TTM, target temperature management if possible. And then the E exposure, expose the patient, look for any signs of trauma, any bleeding or any rashes or anything that can be needed to be addressed. After this, it will be about the transfer to the transfer patient, either to the proper definitive management, either to the intensive care or to the theaters or to the cath lab if needed. And of course, as I mentioned before, target temperature management in the first, whether it's about from 34 to 36 or at least to avoid any causes or any increase in the temperature, hyperthermia or fever. And of course, if the patient, and of course, the patient is priority, but of course, if the baby was delivered, it's okay to refer him to the neonatologist. If he's not delivered, try to deliver the baby if he's not delivered yet. And 12 lead ECG, of course, 12 lead ECG and all the other routine bloods, including IBG, if full blood counts, urea and electrolytes, and check for the causes of the arrest in the first place, and reassess the H's and D's and
So
other
I'm happy
causes
with
of
your
the
answer. So I'm going to move on. Okay. So this is how it actually happens in the exam. So you're given a comprehensive answer. I'm happy with it. I've ticked all the points which I had in my notes. So I'm going to move on. So these are the answers I had. Reassess A, B, C, D, E, as Fatih mentioned, and especially assess the fetus, get a obstetrician to review it. CTG, they may order one, and transfer to theta if needed, and decide on the destination where the patient is going to go, and more investigations why the arrest happened in the first place. So we have this CTG once the obstetrician was doing the assessment, and who is available? Priyanka, are you available?
Yes, sir.
Yeah, if you can have a crack at the CTG, what do you think is going on? If you're not comfortable, we can put it to the audience.
Bradycardic.
Yes, Marcos, welcome. Anyone else? So they may put out any images or data interpretation, even if it's not.
No.
Yeah, yes, Dr. Mohammed.
I think there is during uterine contraction, there is no change in the pulse of the fetus. So that means fetal in distress. So we need to deliver as soon as possible.
Excellent. So the lower waveform is the uterine contraction. And this waveform, can you see my laser pointer? Yeah. This waveform is the heart rate. And each box is like 1 minute duration. So over like around 10 minutes duration, there are 2 uterine contractions here, which is pretty much normal. And the heart rate in the normal range should be in 110 to 160. And other normal features are heart rate variability. There should be variation of 5 to 25 with every, which is spontaneous, which is normal and suggests child is healthy. But here there is no variability, and the heart rate is below the normal range. So this is actually fetal bradycardia. And other features we see in the CTG, if you remember your MBBS days, or like accelerations and decelerations. So with uterine contractions, you might get a deceleration corresponding to a peak of uterine contraction. That will be a early deceleration, which can be normal. Right? Just with uterine contraction, increased pressure for the fetus, and fetus is hypoxic for a while, but it's recovering back once the uterine contraction releases. Then there can be late deceleration, like if the deceleration happens over here after a period of like uterine contractions, or if it's not related to the uterine contractions, that is a red flag. Basically, it means like child is hypoxic irrespective of uterine contractions, and that's a sign of fetal distress and needs to be emergency delivered in an urgent basis. So this is CTG, which is having suggestive of fetal distress, sustained fetal bradycardia, which is not good, and child needs to be delivered ASAP. So the patient is transferred to the operating theater immediately, and emergency C-section is performed under GA. A 3.1 kilo neonate is delivered, required intubation, continued to have significant brady, and intubated and transferred to NICU. The mother got invasive lines inserted right radial artery and left IJ CVC. And following delivery, the obstetrician remarks such like excessive oozing of blood from all the suture lines in the uterus, and the anesthesiologist notices bleeding at all the venipuncture sites and the presence of blood-stained urine. So she is oozing out of everywhere. And these are my next questions. Who is next available? Pavan, are you there? Hassan, who wants to answer this? It's open to the
Okay, I'll answer
audience.
it.
Yeah,
I'll
sure.
answer
Go
it.
on.
Okay.
Yes, of course.
The most likely diagnosis, of course, will be DIC, disseminated intravascular coagulopathy.
Excellent.
Of course, it has multiple causes in this context, but our priority now is to stabilize the patient. So, of course, which will depend on judicial blood transfusion. Of course, at some point we might need to activate the major hemorrhage protocol, but in case of DIC, it's about the right blood product to be transfused. So
Yes, Dr. Fatih, if I interrupt you here, so just try to answer the question. You are absolutely correct in doing the treatment, but the question, it's not going to gain you marks.
Okay, laboratory assay.
Yes,
Laboratory assay,
yeah.
either I'll do thromboelastogram or rotem. In addition to this, I'll ask for fibrinogen levels, full blood count, coagulation profile, including INR, BT, BTT, and other D-dimer and other DIC profile needed for this patient. But especially, I'll focus on fibrinogen level and full blood count and BT, BTT, and INR.
You are absolutely
And
correct. And what you are expecting in those tests? What derangement do you expect in those
I'd
tests?
expect, of course, fibrinogen to be below 1.5. I'd expect the platelets to be below 50. I'd expect the HP will be below 7, and I would expect, or 8. And I'll expect as well increased BTT time, increased BT time, and increase INR levels. And increase the dimer, of course.
FDBs.
Exactly. So these are the other derangements which we expect, but I don't know if they have it on their answer sheets or not, but I have put everything which is possibly deranged from DAC, prolonged PT, APTT, low platelets, low fibrinogen. HB is not a part of criteria to say it's DIC not. There is a scoring system based on the International Society of like thrombosis, which suggests like score of more than 3 suggests DIC. It's based on platelet count, fibrinogen, and INR. So other derangements, elevated D-dimer, FDP, and reduced antithrombin time, prolonged thrombin time. If you do a different types of take, you get these findings as well. But as long as you answer the pertinent things, that's going to fetch you the marks. Moving on to the case, as you said, she needed blood products. The interoperative team commenced blood products. She required 9 units of red cells, 6 units of FP, 10 units of cryo, 2 pools of platelets. And during the resuscitation efforts, she continued to have bleeding and had a hysterectomy done. And we have sent off the coagulation panel, which has come back now. So the PT is prolonged, INR is 1.8, APTT is prolonged, fibrinogen is very low, platelet count is low, and you do a blood gas, which is having these parameters. You can note it down if you want. So next question is going to be based on the ABG. So have a good look at the ABG. Dr. Aitham, do you want to take this question? You are ready to answer the previous one.
Yeah, sure.
Yeah. So it's just interpretation of the ABG. What do you infer from this?
This is a case of metabolic acidosis, perhaps lactic acidosis. But there is associated with respiratory acidosis also, because according to the correction, 1.5 into bicarb plus 10 comes out to be 30, and it is 38 PCO2. So there is mixed metabolic and respiratory acidosis. FiO2 is 0.7. So there is hypoxemia also. Perhaps DA gradient is also elevated here.
And why do you think the lactate is elevated? What's the reason for this acidosis, lactic acidosis?
Type A lactic acidosis, perhaps because of hypoxemia, which is occurring because of hypoperfusion in the tissues owing to low blood pressure.
Yes. So you did mention increased AA gradient. Yeah, that's absolutely correct. And PCO2, what do you expect PCO2 for a pregnant patient? This patient is, of course, intubated, but if in a normal pregnant
Respiratory
lady,
alkalosis is normal. Usually it is lesser in pregnant patient, but here
Yeah.
also according to the Winter's formula, 1.5 into bicarb plus 10, it should be 30 at least, and it's coming higher. So that's why respiratory.
Yeah. So there is some VP shunt problem going on as well, ventilation perfusion mismatch, which is causing this high PCO2. So there is some component of respiratory acidosis as well. You are absolutely correct. And that's what basically I had in my answers. So moving on arrival to the ICU. So now the surgery is done. She had some blood products. She has come to the ICU. She is intubated on noradrenaline infusion, moderate doses. To supplement the volume, she is still requiring some fluid boluses and ongoing noradrenaline requirement. And the anesthesiologist placed a pulmonary artery catheter as well. And this is X-ray on arrival to the ICU. Any volunteers to interpret the X-ray?
Would you like me to answer?
Yeah.
Okay. Go for it.
Who would like to answer? Me or?
If anyone else is there, you can go for it. But yeah, I'm happy with whoever answers.
Okay, I can see that it's the image is not that clear, but from what I can see now, that first the airway, there is a tube which is a little bit, although it is above the carina, but it is a little bit deep inside, but at least 1.5 centimeter above the carina at least. I can see regarding the lungs, there are bilateral infiltrates more on the left side. I'm not sure if there is pneumothorax on the right side or not, but as the image is not clear, but I'm not sure. I cannot see any lines attached. Maybe there is lines, but I cannot see them. But I cannot see any lines. With the quality image, the quality is. I'm trying to enlarge it, but maybe I'm not sure if there is pneumothorax or not, but maybe not. But anyway, bilateral infiltration more on the left side, and of course the other than the lines, which I cannot see any lines, I can see an NG, which is either this an NG or pulmonary artery catheter. I'm not sure, but it looks like a pulmonary artery catheter for me. I think attached there because it is inserted from the left internal jugular vein, so it's most probably pulmonary artery catheter, which will seated, I presume. It's above because it's above the left main bronchus by about 1 to 2 centimeter. Regarding the other bones, I cannot see any fracture bones. I cannot see any surgical emphysema. I think that's it for now.
Yes. Anyone else have anything to add? I think it was a comprehensive answer by Dr. Fatih. Apologies for the poor image resolution. I tried to make it more visible, but this is the best I could get it. Yes, this is a pulmonary artery catheter. Maybe the tip can be advanced a bit more if we need to wedge it, but we need to see the trace to see where exactly is the tip. And the endotracheal tube is a bit low lying. Might benefit from pulling it back a bit. And there is bilateral infiltrates. And what do you think the infiltrates are because of?
Most probably, the infiltrates can be different causes. Can be ARDS due to the inflammatory process, which combined of course, which was due to the cardiac arrest and the post-cardiac arrest and the post-cardiac arrest. Sorry, due to the cardiac arrest and the post-cardiac arrest and all the other. Can you hear me?
Yes, I can.
I think
there is background. Dr. Nidhi, if you can mute yourself. Sorry.
You can mute them, I presume.
I don't know.
You can mute them.
If you can.
Okay.
Yes, I have muted her.
Okay,
That's better.
thank you. Thank you. So what's the question? The question, what are the causes of the infiltrations? Filtrates. Of course,
Yeah.
the infiltrates either can be infectious infiltrates or cardiac infiltrates or hypervolemic infiltrates or inflammatory infiltrates. Inflammatory infiltrates, of course, can be either due to any trauma or any major surgery or any major inflammatory process which has happened to the patient. And in this patient, we had a lot of inflammatory process which has maybe have exacerbated this kind of ARDS-like picture. Of course, we have to rule out other issues like cardiac cause, like pulmonary edema, hypervolemia, and to rule out as well infectious causes. And of course, after major hemorrhage protocol or massive or transfusions, we have to rule out the TRALI and the TACO and other inflammatory process related to the transfusion.
So this has happened within like few hours, and basically she was normal prior to labor. So the inflammatory process does take some time. So what is your most likely clinical diagnosis? Most common you face?
I would go with either TACO, TRALI, or amniotic fluid embolism.
Okay,
Wasn't that
right. So differentials we have discussed. Anyone else have any other differentials in your mind?
Aspiration during arrest.
Yes, Dr. Mohammed?
Aspiration during arrest.
I didn't get you, sorry.
Aspiration.
Aspiration, excellent, yeah. But the infiltrates may not happen immediately, right? It might take few, maybe at least 24 to 48 hours to develop such infiltrates. But it can happen with the hypoxia, peri-intubation. But there was no clear history of aspiration in this case. You have checked with the anesthesiologist who intubated. There is no clear aspiration here. But it's definitely one of the differential. And we discussed TRALI with a lot of blood products. Yes, it's in the differential. Anything else? We discussed amniotic fluid embolism.
And pulmonary embolism, just pulmonary embolism can be a cause as well. Cardiac pulmonary edema can be a cause.
Cardiogenic, so it's kind of a peripartum cardiomyopathy, you mean? Yes, accepted. She is severe preeclampsia. Can that cause this picture? So the X-ray to me looks like acute pulmonary edema. So with that in mind, or ARDS, with that in mind, I have to work up my differentials and most likely diagnosis, which fits. So what are the major problems in this patient so far we have seen? If you can summarize.
The major problem first, post-arrest, which at some points needs adjustment, post-cardiac arrest care, and then after 72 hours, neuroprognostication if possible. We have got airway problems which should be addressed regarding the intubation and adjustment with the endotracheal tube. We had a breathing problem, which we might anticipate difficulty in breathing and needs lung protective strategy to be addressed. And of course, we have a circulation that need to be treated properly regarding with judicial fluid or blood products administration in addition to vasopressors or inotropes if needed. And we have to properly diagnose the patient, diagnose the cause of arrest, and diagnose the current condition of the patient, because we may expect some sort of deterioration. And we need to assess her neurological status properly, either now via the GCS clinically, and if she's stable enough to be shifted to the CT for a CT brain, just to have a baseline finding of her lung. And after this, of course, TTM, target temperature management.
If I want to summarize the main issues we are dealing, so sudden cardiac arrest during labor, yes, DIC, and pulmonary edema / ARDS, correct? So with this in our differentials in mind, what do you think is the most likely diagnosis? Let me see if we can convince you with my diagnosis.
Pulmonary edema, I think.
To the audience. Pulmonary edema, yes, but why? What's the unifying diagnosis? What's caused the arrest?
I would say
Cardiomyopathy.
I'll go
Peripartum
with
cardiomyopathy doesn't cause DIC like picture in the.
amniotic fluid embolism. Amniotic fluid embolism. And that's what I'm going to say. Amniotic embolism.
You are bang on, Dr. Fatih. That's yeah, it fixes the picture. Amniotic fluid embolism is a diagnosis of exclusion, basically. We don't have time here. Of course, we can evaluate, do the echocardiogram, do the BNP, rule out peripartum cardiomyopathy, wait for the septic markers to rule out sepsis, and get a CT chest, CT brain to rule out stroke or eclampsia-related complications, and send a tryptase for anaphylaxis. But if everything comes back negative, only then we move in the direction of amniotic fluid embolism. And just with the clinical picture, I would say it fits the picture of amniotic fluid embolism because it's acute cardiorespiratory failure. Patient had DIC, and the timing was like during labor or within 30 minutes of delivery, which is the criteria for clinical diagnosis of amniotic fluid embolism. So I think this patient had amniotic fluid embolism. And most of the clinical cases which you get in the actual exam or like actual cases which have happened, they are not fabricated. They are like taken from case reports or personal experience of the examiners. I personally know an examiner who is working with me who just picks up cases from where he's working. So we may not find all the answers in a patient. We just the process of how do we go about the differential, how do we go about evaluating the patient, how do we treat them. So regular ICU stuff which we do in a day-to-day life, it's not like fabricated or always as a diagnosis. For example, my clinical case didn't have a diagnosis during my exam. It's just about how you proceed. How do we evaluate these patients and get the opinions and move forward with this patient. So patient might land up having any complication, and how do we proceed dealing with them? That's all about giving this exam. And the patient did not have any fever prior to this. So this fits the picture of amniotic fluid embolism. And a bit more about amniotic fluid embolism and what's actual pathophysiology, if anyone has read about it. Any takers?
Okay, the amniotic fluid embolism, this pathophysiology is not known exactly, but the most acceptable theory based on the autopsies that it's most probably due to either there is direct occlusion. Sorry, hello, can you hear me?
Yes, go on.
Either direct occlusion of minute blood vessels due to the leakage of some of the amniotic components into the maternal circulation, and this can cause ARDS-like picture and the DIC pattern. The other theory that is about immunological theory due to the maternal genetic and amniotic components which have been leaked into the maternal circulation as well, and this inflammatory process is which exacerbate the thrombotic process in the minute blood vessels in the lung fields and other DIC DIC picture, which can be manifested in the severe amniotic fluid embolism syndromes. So it's mainly a syndrome. That's just like a fat embolism syndrome. Looks like a fat embolism syndrome, but it doesn't require anticoagulation or thrombolysis or any of the other issues associated.
Brilliant. Yes. So it's not like actual like pulmonary embolism, but it's more like a anaphylactoid reaction to the fetal products entering into this maternal circulation. It doesn't happen to everyone. Most of during delivery, there is some leakage of fetal products into the circulation for the mother, but not everyone develops this reaction. And it's complicated by a SIRS-like reaction, ARDS, complement activation, clotting factors activation. And that's why we have this picture of DIC. And the reason for acute collapse is basically pulmonary hypertensive crisis, which causes acute right ventricular failure and subsequently left ventricular failure. That's how we land up in pulmonary edema. So this is what proposed theory behind this. And there's no clear risk factors which is modifiable. There are suggestions, but there is no clear risk factors which can be modified for amniotic fluid embolism. So great about that. And let's move on with the case. We have 5 more minutes. I'll try to wrap it up. So 3 hours after the ICU admission, she has another hypotension episode. She deteriorates again, still responsive to fluids, and the noradrenaline requirement continues to go up. She's being transfused more blood products. She continues to wound from her bleed from her abdominal wound and many puncture sites. And you repeat a blood gas, still acidotic, although slightly better. Hemoglobin is slightly incremented, platelets 85. Iron are slightly better, but still elevated. Fibrinogen remains low. And the nurse mentions the abdomen is getting bigger and bigger. And the intensive care medicine consultant does a focus suggestive of hypovolemia, collapsing IVC, and this picture here in the fast scan of the abdomen. So what's going on?
Patient bleeding, perhaps.
Yes. Go for it. Is it Priyanka?
Yes, it seems like
Yes.
patient is bleeding intra-abdominal because of the
Excellent.
because there's a collection of the blood in the Morrison's pouch.
Yeah.
So maybe this is hemoperitoneum, which is leading circulatory collapse and hypovolemia. So we need to put in 2 large bore IV cannula and resuscitate the patient with fluids. And we
Anything
should
else?
also arrange for blood. Blood grouping cross-matching sample should be sent at the earliest, and we should arrange for more bloods and blood products. Simultaneously, TEG thromboelastograph or ROTEM samples should also be sent to correct the coagulopathy if need be. And
multidisciplinary team with surgeons and
exactly. Yeah,
OB.
get as much as help as possible. Yep.
I think you need to go back to theater to maybe there is
of
a
course.
bleeding. Uterine
That's
artery
what we always push
dilation.
for, right? Ask the surgeons to take it back to theater and solve the
so
puzzle.
we have already done a hysterectomy. Might be we will benefit with intervention radiology call. Maybe they can embolize some vessel and.
Yeah, getting nowadays surgeons are not keen on taking the patients back to the theater anyway. They ask for a CT angiogram first. So probably that's what would end up happening to this patient, and potentially re-exploration, or if there is an arterial blush or somewhere with a clear target for interventional radiology. Yes, cath lab intervention. And major emergency protocol must have already been in place. But if not made already, it's a polished way to answer in the exam. Put out a major hemorrhage call, and the blood products keep coming. There are pack A and pack B based on the setup you are working. Pack A has red cells and platelets, and pack B has the rest of the products. And we didn't mention tranexamic acid so far. And if not given already, this is a good point to give tranexamic acid. There is good evidence base in the postpartum period for PPH. You can mention the evidence as well here if you are using tranexamic acid. Yeah. And of course, we will get the surgeons involved, see if they are happy to take her back to theater or get a CT angiogram and involve the interventional radiology. So this patient, this is another question. What do you think is the role of recombinant factors 7 here in this patient when we are suspecting amniotic fluid embolism, given she has had multiple blood products? And hematology is another specialty which we need to involve here. If you are giving so much blood products to a patient still struggling with the bleeding, hematology might help us with giving some suggestions or sourcing a different test or like recombinant factor 7. So multidisciplinary team, that you can mention that again in your answers, like getting the hematology involved. So what do you think about the role of recombinant factor 7? Does it have any role? What's the evidence basis behind this? Anyone?
Recombinant factor 7 is approved for hemophilia A and B management only, but yes, we can always use in this patient who is bleeding profusely.
Salvage procedure.
Yeah. So any major hemorrhage, this can be used as a salvage, but specifically with amniotic fluid embolism, it has been shown to increase the morbidity and mortality in a systematic review and meta-analysis. So that's based on a 2019 article. I don't remember the authors, but it is not advisable. So that's the answer for recommendation. So what happened to the patient? We had a consultation with hematology, advised further blood products, cryo and pools of platelet FFP. She was not given recombinant factor 7A because of her ongoing acidemia and suspicion of amniotic fluid embolism. And after 20 minutes, she did go back to theater. And after this transfusion in the theater, bleeding settled and she was brought back to the CT ICU, and she had ongoing management for her ARDS and coagulopathy. She did improve gradually over the next 24 to 48 hours, did require some renal replacement therapy, but eventually the patient made it out of the ICU. So with any kind of exam, always there is a question, expect a question on long-term outcome of the patient and what you're going to do about it. Some questions related to the ethics, medical ethics. So what are the long-term effects the patient might face given she made it out of ICU?
A patient might have some neurological sequel, might be there can be some cardiac damage, could be permanent because CPR has patient has also received CPR, and might be she will need some diuretics to counteract her heart failure, or and like she has required CRRT also, renal replacement therapy, so she might be in a future risk for AKI, and she might require the same in future. So the families should be counseled regarding the need for the organ support might be in future.
Yes. So I put out everything that can happen to the patient. I've taken this from the Amniotic Fluid Embolism Foundation. And so they can have severe neurological issues, Sheehan syndrome, even severe hypotension, pelvic floor dysfunction, chronic pain, kidney dysfunction, and more importantly, emotional and psychological damage to the patient as well as the family. So which can be quite difficult to manage. And nowadays we have a post-critical care follow-up recovery clinic where we see these patients come back to us with a lot of problems where we address these issues. So that's the end of today's session. To summarize, we have visited the topics of obstetric cardiac arrest, DIC, acute pulmonary edema, amniotic fluid embolism. Next class, we will see different issues. And some of the sources I found really useful were RCOG guidelines for maternal collapse and amniotic fluid embolism foundation website. Always like FFICM preparation materials were really helpful for my exam, particularly Ariel Davis. So I would suggest you have a look into those materials. Thank you so much. In the next sessions, I would suggest everyone to participate. That's the most important part you can take out of these classes in this fast secondary course. The more you practice, more you will feel confident for the exam. It's a tiring exam. You would have prepared for a long duration, and the exam you need to focus, read all the questions, and come out with the answers. So you need more practice. That's only going to, even if you know all the knowledge in the world, you need to put it out at the right time. That's what is going to make you successful. So I encourage you to all come out and answer. And if you can have the videos on, it would be better to interact with each other. I would really appreciate that. If you have any questions, I'm happy to take it now. And those you want to leave can leave as well. Thank you so much for staying throughout the class. Any questions? Any feedback?
Thank you, sir, for a very nice lecture. Actually, I much benefited. Thank you.
That's very helpful as a feedback.
Excellent,
Thank you.
excellent. Thank you.
If you have any questions, you can ask in the chat as well. I will put out my WhatsApp in case you need to contact me. You can get in touch with you later. That's my UK number
Where you put in chat box?
in the chat box. Yeah. If you need any advice, feel free to contact me anytime.
Thank you.
Don't call me, but I will be responding in WhatsApp.
Thank
Okay.
you.
Let's
This is
find the session.
India
Okay.
extension or what? Indian?
This is UK.
UK, huh? Okay.
Yeah. So
Yeah.
440444. Yeah, 44.
0044. Yes.
Yes.
Thank you.
Hope you had a useful session. Let's meet in the next class. Thank you so much.
Well, sir, we should bind up the session. It was really a nice session. We'll schedule a class soon. Thank you.
Sure. Thank you so much, Fatma.